Aronson here. Welcome to Top Med Talk. Today's Top Med Talk is the Perioperative Care Practicum Taster Session. It features, in this order, Professor Sol Aronson, a tenured professor at Duke University and Executive Vice Chairman in the Department of Anesthesiology, Professor Monty Mythen, Smith's Medical Professor of Anaesthesia and Critical Care at University College London, and of course our Editor-in-Chief here at Top Med Talk. And finally, there's a piece from Professor Lee Fleisher, Anesthesiology and Critical Care at the University of Pennsylvania. We're releasing this podcast today, firstly, to remind listeners and subscribers to our mailing list that the Chicago Masters course, a Perioperative Care Practicum, is being streamed live on our website as it happens at the moment. So get yourself to topmedtalk.com to hear this kind of medical information. It will be going out live. It will later be released as a podcast, but get yourself to topmedtalk.com to hear this kind of thing coming live. A Perioperative Care Practicum.
Top Med Talk.
In the U.S., we're straddling that very fine line between volume and value, and depending on what zip code and what region of the country we live in, the length of that tightrope, however narrow it may be, depends on the regional sort of variations in legislative and regulatory rules. But for the most part, most of us today, as we sit here and live and breathe, still recognize that the majority of the payment for services that are rendered in healthcare are still a fee-for-service world. We're all so very paranoid about having to be prepared for the risk-bearing world and the value-based world of being accountable for our actions, where we really have to own the consequences of bad decision and bad risk. But let's be honest, most of us are just simply living in that fee-for-service world. And, we have a saying at Duke, and it's probably true everywhere, sell no wine before it's time. We want to hold on to that moment as long as possible. But when that transition occurs, it's going to be a very steep, if you will, slope toward value. And so I think it's fair to say that, healthcare is continuously becoming more and more burdensome. We're spending nearly $3.5 trillion of our gross national product right now in healthcare. It's clearly unsustainable. Regardless of what side of the fence your political persuasion is, we are having to confront the reality that we are going to have to live in a value-based world. And perioperative care, perioperative medicine, is really uniquely suited to have us be a part of that discussion in the broader landscape of population health. What we do in the small segment of perioperative medicine does matter, and how we go about our business and how we manage to that is very important. And I just want to have that perspective be sort of resonating with all of us in the room. There's so much opportunity, even in a fee-for-service world, notwithstanding going forward to a value-based world, for us to tighten up the way we manage ourselves and the way we mitigate that risk. The cost of unnecessary or uncoordinated care is extraordinarily expensive. That's particularly true within the hospital and within the physician care coordination setting. These are some high-level, if you will, statistics, but I think they give perspective of the $3.5 or so trillion that we spend in healthcare in this country. There's an enormously expensive burden on needed services and efficient delivery of services, poor care coordination, just missed opportunities, as well as redundancies and, frankly, other mistakes. And so we do matter, and I think it's really important, again, to have this perspective. We all know that there's a small segment of the population that consumes a disproportionately large percent of that expenditure. That's even more disproportionately true in the more elderly population. And so what we do and how we begin to provide a value proposition to the broader discussion of healthcare through the lens of perioperative medicine is really meaningful and something that we should embrace. But what I wanted to do here is give us sort of a perspective of what's going on in the world around us. While we may go back to our institutions and sort of get cozy to our own unique environments and cultures, there's great mergers and acquisitions and horizontal and vertical integration going on around us. Kaiser Permanente is the largest example of a single carrier. It's probably valued at around $65 billion. HCA is right behind it at about $45 billion. Get a perspective of where you are in your institution and what the value of your practice is when I share these data with you. UPMC, the largest academic single provider, is valued at around $17 billion. Geisinger is around $9 billion. And while that's going on, there's interesting horizontal integration going on as well. We just saw in the newspaper a few months back that Advocate in Chicago merged with Aurora in southeast Wisconsin to form an $11 billion corporation. Some of the large players in the healthcare provider sector are affiliating either with medical partners for provision of delivering direct service or partnering with pharmaceutical agencies or scripts. And so healthcare is changing rapidly around us. And whether we want to keep our head in the sand and pretend that it's not affecting our zip code or our region of the country, notwithstanding, that's simply naive and I think foolhardy, because it is happening, and it is happening without a political agenda. It is simply happening because the free market is dictating that it's happening in this country.
Top Med Talk.
It's interesting how long it took for the European Society to embrace perioperative medicine. It came last year as being a highlight, and only the year before, the Chinese Society of Anesthesia, attended by more than 10,000 people, was titled Transition from Anesthesiology to Perioperative Medicine. So the world is changing rapidly in this space. And I really put this up to highlight the fact that the lecture is an eponymous lecture, and it's named after Sir Robert Macintosh. Now, Sir Robert Macintosh is very well known to many people as being the first professor of anaesthesia outside of the United States of America. But also you probably know the Macintosh Blade. So the curved laryngoscope blade is the Macintosh Blade. It's based on a Boyle-Davis gag. So during a tonsillectomy, Robert Macintosh looked over the shoulder of the surgeon doing a tonsillectomy, and with this curved support gag in the mouth, he had a fantastic view of the target zone. And he developed a laryngoscope with a curved blade rather than a straight blade. Now, around the time he was doing that, as one of the first professors in the world, the big obsession for anaesthesia providers was maintaining an airway and keeping somebody asleep and alive. That was the big aim to that stage, the development of tubes, of airways, of novel drugs, of syringes, of lines, etc., to enable those things. But as early as 1949, Sir Robert Macintosh said there should be no deaths due to anaesthesia. And if you read on about what he had to say related to this statement, he said we've now really got to move on from this obsession with the airway and keeping people asleep and alive to the fact that when we do that in very many patients, they still die as a result of the quality of their perioperative care and or how they've been prepared for surgery. And he said that in 1949. And he formed within the Association of Anaesthetists a group to say we have to move on to start to look at the whole picture of patient care, such that nobody should die due to anaesthesia, and really nobody should die during elective surgery. Now, I said at the beginning in my opening statements that evidence-based perioperative medicine was formed to put on educational meetings and to bring people together to share ideas 20 years ago. The Royal College of Anaesthetists in the UK made its transition from saying, I think we understand what anaesthesia providers do, to embracing perioperative medicine on the 23rd of January 2015. So that's a fairly typical incubation period for new ideas. As I said earlier, I get the impression that there's an inflection point around the world, that everyone is now embracing this transition from the provision of anaesthesia to the broad care of patients under the guise of perioperative medicine. So here's our document from the College of Anaesthetists, released January 23rd, 2015. You can find it on our website. The document is called Perioperative Medicine, the Pathway to Better Surgical Care. It's accompanied by a short animation that runs for about 5 minutes, which has been watched all around the world, we believe now millions of times, which is a sort of sliding door experience of a patient who has a traditional care model, as described by Sol, where his problems are itemised but not necessarily treated. He has a bit of a wobble. He ends up on ICU reactively, develops some acute kidney injury, which becomes chronic kidney injury. The second time we replay the story, he goes through a perioperative pathway similar to that described, the poet experience. And he's tuned up and tweaked up at every angle. He's proactively put on intensive care. he doesn't develop those problems, and he goes home and everything's fine and dandy, as we hope it should be. Now, importantly, on the left-hand side, the document we wrote collectively and published is a description of what we believe is in the patient's best interest. It's not the answer to how we get to that place. There's a lot of unanswered issues here, which I'll come back to. This is a picture of our president, sadly died relatively recently, J.P. Van Bassau, immediate past president of the Royal College of Anaesthetists, who very much drove this agenda. He harnessed the energy of those who were interested in it and went public to make a commitment that the Royal College of Anaesthetists is committed to developing a collaborative programme for the delivery of perioperative care across the UK to deliver more efficient healthcare to improve patient outcomes and quality of life. Now, in the build-up to that was really quite controversial because there was quite a lot of anaesthetists, physicians in the Royal College of Anaesthetists, in a broad group, who were quite resistant to the idea that we would get away from our traditional duties and responsibilities. In other words, we've been trained primarily for the provision of anaesthesia, we already regard ourselves as perioperative physicians, etc. Why was the time right to consider that transition? Well, you've heard about a lot of this from the first speaker, Sol Aronson. This is our UK numbers that relate to the challenges we have perioperatively. So in the year before we published that document, we believe of our budget at the time of about 100 billion UK pounds in England, spelt by the National Health Service on healthcare, 16 billion of that was spent on elective surgical care. So that's 16% of the budget. 10 million people had a surgical procedure. Now, I told you our population's 60 million. So even in a little country like ours that doesn't actually spend that much money on healthcare compared to the USA, 1 in 6 people had a surgical procedure. 25% of the population have the long-term conditions that Sol was referring to. Great news, the baby boomers coming through, that the population's getting older. We still have a challenge in the delivery of post-operative critical care in our country. So there's only a 1 in 5 chance, if you have major non-cardiac surgery, that you'll be able to get into a critical care environment. We know who the high-risk patients are. So for all the reasons that have been articulated already, they're relatively easy to spot. They're the patients who are older with multiple comorbidities. Now, they make up a minority of the patients. They make up about 20%. But 4 out of 5 of the deaths occur within that 20%. So it's not hard to start to work out where you need to focus your energies and your efforts. The final thing is, currently, even though around the world we're repeatedly reporting that there are long-term harms associated with what superficially appears to be successful surgery, i.e. the joint has been fixed, the tumour's gone, but the patient's had a silent heart attack or now has long-term kidney injury, many of our systems have no way of tracking that. So we don't actually completely understand the consequences of our actions. Now, in the UK, in the build-up to embracing perioperative medicine as a transition, we'd had pretty good success with our National Enhanced Recovery Programme. So in 2009, the government made a decision to rapidly spread enhanced surgical recovery, which you'll get the details of that. I know you all know about this already in the next session. It will concentrate on the rest.
Top Med Talk.
That in the US, you can see that our total expenditures on health care and social services is not that different than the rest of the world. We're actually equal to about the rest of the world, or we're in the middle of the pack. The thing is, we've flipped it. We pay for care, we don't pay for health. And if you were responsible for a population, if, for example, you're Boston Children's, I was just talking, my cousin actually is the chair of pediatrics up there, and they have a Medicaid ACO, and they're now responsible for taking care of these kids. You may pay for dental care, because in children, poor dental care, dental caries can actually lead to worse outcomes. The smoking that Sol talks about, some of these clinics are huge, and if you're Geisinger and you're both the care deliverer and the insurer, you may buy a patient a refrigerator. You may actually, what some people have done is they've gone to Blue, they supply food after you can order it online. Blue Apron. There are centers that actually have started to send patients home with Blue Apron meals to improve their healing after surgery. Really interesting concept, but if you get paid for the total bundle, it makes sense. If you get paid fee for service, you never do it. So in fact, people have looked at this. This is a wonderful sort of analysis. How can we work with the entire health and change that paradigm? And payment will drive this. How much you're in an advanced payment model will make a difference. This is the idea of how we'll be paid, because that's how it was asked for. This is the payment to provider, no link to value. I'll show you CMS and sort of Sibelius's approach that we're getting to value payment. That really is only 2 to 3%. That while we say 30% of our care, 50% of our care is paid, it's actually that 2 to 3% margin. So if you do more volume, you can overcome the negative payments around quality-based care. The alternative payment models is the bundles. That's in 3. Now, we know that Secretary Price, being an orthopedic surgeon, did not want anything to interfere with the independence of physicians. And that's why he was against bundles. He actually thought bundles worked, from everyone I know at CMS. He was in favor, but he wanted it voluntary. And we know that Azar and the current administration is now thinking again, and I'll show you some of the new bundles that have come up. And lastly, population-based. And anybody here from Maryland? One person. You have an interesting system. But it could become the model for the country, and people need to be aware of it. So this idea and this goal of getting to 85% linked to value-based purchasing is only the 2 to 3% that's attached to MIPS. It's only to that small percent that's attached to the change in the total amount of money you will receive from Medicare in the payment updates. But it was the first step. And again, this goal of 2018, some people will say it's true, it's 90%, but others will not. In fact, Saul's co-author, Mark McClellan, said, CMS will move a little bit, but he actually got industry, the insurance industry, to move even faster than CMS. So if you think that because CMS underpriced slowed things, you should talk to AHIP, the Association of Health Insurance Providers. You should talk to your local Blues or to Aetna. They are actually going to accelerate it. My CEO does not want to say we have any population health programs, but we're responsible for 160,000 lives under our Blue Cross contract. It's a different name for the same thing. We are responsible for their total cost of care, and I'll talk about where we can make a difference there. The thing that CMS learned, and the CMMI, the Center for Medicare and Medicaid Innovations, learned, is it works. That as you actually do these alternative payment models, as they actually started to ask the question and attach it to payment, and people focused, there was marked improvement in VAP, in early delivery by C-section, central line. Everyone says that 15 years ago, we couldn't eliminate central line infections, and they are much, much lower. Now, the interesting question, is it Peter Pronovost in the checklist, or do you read Mary Dixon Wood's work, who's from Oxford, where she says it's actually a culture, it's the campaign that makes the difference. And can you change the culture in your hospital, in part by developing all the things that Saul and Monty talked about for the country or for Duke.
Top Med Talk.
These pieces were originally streamed live as part of EBPOM USA Master's Course, the Perioperative Care Practicum that happened earlier this year. If you want to hear similar talks but in full on our website, all you need to do is go to topmedtalk.com. That's topmedtalk.com. Don't forget, of course, you can meet the Top Med Talk team. All you need to do is turn up to one of our meetings. ebpom.org/meetings is the place to find out about that. ebpom.org/meetings. Also, if you haven't yet signed up for our mailing list, make sure you do that on the Top Med Talk website. As soon as you're part of the mailing list, you'll then know when we're going to be streaming live, as indeed we are today and across the weekend, here on Top Med Talk. Go and check it out now if you can. www.topmedtalk.com.